So this session is on genetic testing and surgical implications. We have two speakers here with us today. Dr. Jennifer Garreau is a board-certified general surgeon and fellowship-trained surgical oncologist with Legacy Medical Group and Surgical Oncology. She specializes in breast and skin cancer. Dr. Garreau earned her medical degree from the University of California, Los Angeles School of Medicine and completed her internship and residency in general surgery at OHSU. She completed a fellowship in surgical oncology at the John Wayne Cancer Institute in Los Angeles. She's a board member of Susan G. Komen Oregon and Southwest Washington, and has earned numerous honors and awards for her breast cancer and melanoma research. And Gina Westhoff, Dr. Westhoff is a gynecologic oncologist with Legacy Health. She graduated from Johns Hopkins School of Medicine, received the OHSU Resident Research Award while a resident there, and completed her fellowship in gynecologic oncology at the joint UCSF Stanford program. Among other practice areas, Dr. Westhoff is focused on improving the standard of care through the use of minimally invasive surgical methods and enhanced recovery after surgery pathways. She serves as a medical advisory board member for the Ovarian Cancer Alliance of Oregon and Southwest Washington. And I work as an inpatient nurse at Legacy Good Samaritan. And in that role, I can attest to the fact that the women who partner with Drs. Garreau and Westhoff for their cancer care hold them in the highest regard. They're widely known to be physicians who take the time to hear and to know their patients, and that, coupled with their experience, competence, and expertise, makes all the difference. So to get us started, Dr. Gina Westhoff.
All right, well, welcome, everybody. It's nice to be here today. Such a wonderful conference, and it's glad to kind of be on. I'm a little bit on the other side of things, you know, the down below is usually what I do. But surprisingly, the breast and the ovarian cancers are very connected. So that's kind of how I've developed an interest in the genetics of these cancers, and really kind of how we work a lot together for women who are at increased risk for both the breast and the gynecologic cancers to kind of help them reduce risk and mitigate their risk as best we can. So I've been asked to kind of talk to you a little bit about the genetics of breast cancer. We're going to talk about hereditary cancer genetics kind of in general, and a little bit more specifically about, should probably say that, about who should get genetic testing, what does it mean when you actually go through the process, and how are some ways that we can actually be better at getting people access to these tests, because they're very important. I am a speaker from Merck on immune therapy and gynecologic cancers, entirely unrelated to today's topic. So we kind of talked about the points of where we're going to go. So hereditary cancer syndromes, we know breast cancer is very common, but there's a high proportion of those that actually can run in families. So there's familial breast cancer and then also hereditary cancers where we've identified a gene cause, something that you would have inherited from your parents, either mom's side or dad's side, that would increase your personal risk. So BRCA1 and 2 are the most common, the ones that we think, well, they're the ones that were the first discovered and the ones that we know the most about. And the carrier rate has been said about 1 in 400 women in the United States actually carry the BRCA mutations. I've read a recent study that in a different population in Pennsylvania, the carrier rate was 1 in 200. So I think it's somewhere in between, like 1 in 200, 1 in 400, which is actually pretty common. 1 in 40 in Ashkenazi Jewish women. That's because of founder mutations that started within that society and has kind of stayed within that ethnic group. And so if you calculate all of that, there's probably somewhere close to 500,000 women in the United States that carry a BRCA mutation. So that's a lot of women. A lot of work can be done to reduce their cancer risk. In addition to BRCA1 and 2, over the past 10 plus years, there have been a lot of other genes discovered that increase cancer risk. And that has just exponentially changed things. So genetic testing, we're looking for these mutations that we better understand why someone may have gotten the cancer and what is their cancer risk in other organs. And it's really important to know and understand what someone's risk of cancer is, because how we treat them and how we manage that risk is unique based on someone's individual or personal risk of cancer, which for some mutations like BRCA, we actually start screening women at the age of 20 to 25, looking for their and managing their breast cancer risk very early. As we all know, early detection leads to cancers that are either picked up early and can be cured. And if the risk is high enough, based on kind of your hereditary picture, we actually might even talk about risk-reducing surgery to really just negate any risk of cancer. So that's kind of why we care about genetics. This is this is a better picture about how common it is. So breast and ovarian cancer are linked. The hereditary breast and ovarian cancer syndrome includes multiple mutations, as I mentioned, BRCA1 and 2 and others. If you look at all breast cancers, about 25% are in that familial or hereditary group. And the difference between that really is familial cases of breast cancer run in families, but all the genetic testing is negative. So essentially that means that there's either been an exposure or there's something else, some other gene that we just haven't discovered yet that's probably the explanation for those cancers. In women, they're about 8% at the time, which is that darker blue pie here. About 8 to 10% of women who we test actually carry one of these mutations I'm speaking of. Ovarian cancer, which is the cancers that I treat, the risk of having a mutation is actually higher, somewhere between 15 and 20% of patients with ovarian cancer are found to have a genetic cause. And then still about that kind of same 25% are either hereditary running in families, familial running in families, or hereditary from a genetic cause. So these are some of those other genes. So in the background of genetic testing, it kind of started out with BRCA1 and 2 being the most well-known, or the first genes discovered. We'll talk about a timeline in a minute. But then as you can see, there are a lot of other genes that have and contribute to risk of breast cancer. And this is important because even now, actually, in my practice, when I'm seeing women, because I do genetic counseling, most women might have only been tested for BRCA1 and 2. But we now know that hereditary breast and ovarian cancer can be explained by many other genes. And so even if you've been tested for BRCA1 and 2, you would benefit from what we call completion testing, where you get the whole panel to look for some of these other genes. These other genes, each of the genes is unique in how much it increases the risk of breast cancer, and we'll get to that at the second portion of the talk. But I see this even today, where women have only been looked at for BRCA1 and 2, and we're missing a significant proportion of women with a hereditary mutation because we've recently discovered all these mutations. Same thing with ovary. We are increasingly understanding more of the genetics about ovarian cancer and adding genes that we do believe would increase that risk. So probably the number one takeaway is that for women who've had genetic testing and who kind of meet criteria, it's really important if you're talking with them, I talk about it every day, what exactly were you tested for? Was it just BRCA1 and 2? Most people don't actually know, and so we have them bring in a report so that we look through it with them, and then we make sure that they've been tested for all of these common genes that we now know can contribute to risk. So very important. This is why it's so important, because the risk is significantly increased. Very different. We should manage women differently based on their individual risks. You've probably seen this before. Breast cancer risk with BRCA is up to, in the 80% range. With ovarian cancer, up to the 20% risk for BRCA2 and actually higher, 40 to 50% in some studies for BRCA1. Thank you. So that's a lot of risk. And you look at the general population, 12% versus 87, that's a big difference. Same for 1.7% is the risk of ovarian cancer in the general population. That's about 1 in 70 women, compared to about in that 20 to 40% range. So this is a big deal. The risk is significantly different, and so we should be treating these women differently and personalizing their care so that we can either decrease the risk of cancer entirely or catch these cancers early when they're curative. Okay. So this is kind of the first big point is a little bit about understanding how the realm of genetics has changed. It's not just BRCA1 and 2 anymore. There are multiple genes that are related to breast cancer and in this hereditary ovarian cancer syndrome. There's also some new information coming out, which is still a little new, about Lynch syndrome and how that may also be associated with breast cancers as well. The good news about getting a panel is we look for everything. And so we might, even though you aren't a BRCA1 and 2 carrier, we're going to make sure we rule out other causes of hereditary cancers with that full testing. So that's probably the big takeaway. Number one, make sure you know what you're being tested for. Make sure you have a copy of those genes, because now is a snapshot in time. 5 years from now, it's going to be totally different. We're going to have more genes that we discover, and you want to empower yourself with that knowledge so you can say, no, I need this now too. Or you can even just ask the question, I've had this testing, is there anything else I should be tested for based on any change in the science? The second big thing that has changed and is kind of an evolution is who should get this testing. So we talk about the genetics is changing, more and more genes are being identified. Well, the actual indications for testing are changing every single year. So I looked back in this talk, I had to kind of, massage a little bit. That last time I looked at the guidelines and had it on a slide was 2017, the NCCN guidelines on who should get testing. These are the updated ones from 2019, and I had to just throw away that old slide because it's so different. Essentially, when I am seeing patients, any patient that comes to me, whether it's for a consult for their gynecologic cancer or genetic counseling, we're doing a full family history. And I know by heart that if a patient has a cancer, there's some cancers that it doesn't matter what age you were diagnosed, you should have genetic testing. And these are ovarian cancer, pancreatic cancer, that's new. We weren't genetic testing people with pancreatic cancer. That's new within the past year. Metastatic prostate cancer, that's also new. We weren't testing patients with metastatic prostate cancer before. We think that there's lots of other prostate cancer genes that we're identifying to help kind of explain that. And then anybody with breast cancer or a high-grade prostate cancer and Ashkenazi Jewish ancestry. So the additions here really are pancreatic cancer and metastatic prostate cancer. I saw a woman yesterday and her grandfather died from metastatic prostate cancer, and truthfully, she meets criteria for genetic testing because, that's now a NCCN guideline recommended, testing criteria based on the new discoveries in the genetics for prostate cancer. So paying attention to that's important. And then we think about other things that are probably, you guys are a little bit more adverse. Breast cancer is currently the recommendation for who should get testing based on a breast cancer diagnosis is age-related, so less than 50, triple negative less than 60, anyone with 2 breast cancer primaries in their history, and then breast cancer at any age and 1 relative with any of those kind of other things we talked about before. So the big takeaway is that we're identifying more genetic hereditary syndromes based on the genes we're finding. And so even next year, we actually might have a change in who should get testing. And I actually think, and we'll talk about this at the end, very soon the indication's going to be that all women with breast cancer should have genetic testing. I'm really biased, so I test most people that are interested, and we'll talk about how you can get testing too if you're interested too. If you might, or if somebody doesn't meet these criteria. Family history is also important, so we also want to prevent cancers in the healthy patients that we see. So, a lot of people come with a cancer diagnosis, but in some ways that's a slight failure in the system because most of those people with a cancer diagnosis probably have a family history that would have met criteria for testing. So if we really want to be accurate and good at preventing cancers, we want to talk to our young women and our young men that we see in primary care and go through that family history every year and see if they have indications or anybody in their family that should get testing so we can better understand their risk. So really, all you have to think about is if that person in front of you doesn't have cancer, does anybody else in their family meet the criteria I just talked about, like I mentioned? Does anybody have pancreatic cancer in your family? Well, either that person should get genetic testing, or if they've passed away, the next closest relative should, so that we can better understand the cancer risk in that family. Okay, so the number of genes that we've discovered has dramatically increased, and that's going to continue to change at rapid fire pace. Based on that, that's led to these evolution in guidelines about who should actually undergo genetic testing. And I think we're going to continue to see the guidelines broaden and be less kind of age-based and specific as we learn more and more about the genetics of cancer in general. Okay, so what happens when you get there? So I do a fair bit of genetic counseling, and this becomes a little bit important because when we talk about access to genetic testing, there is a scarcity in actual genetic counselors that can really sit down with someone and talk through all the pros and cons and the nitty-gritty. We recognize that. Because of that scarcity, women, namely in rural communities, have a difficult time getting access to testing, or it just might be another trip into the city 2 hours away to get genetic testing, like where I'm from, in the plains of Colorado. There's not a genetic counselor there. Probably Denver's the closest one, but that's another hour and a half in. And if you're going through cancer treatment, that's just too much to ask. But it is important that you think about what you would be getting in that option. But there are some options for direct-to-consumer testing, which we'll talk about too, where you don't actually have to have genetic counseling, but there are some downsides to that. Access is good, but you also need to know what you are getting or what you aren't getting. So if you do have the opportunity to have a genetic counseling visit, we do an extensive review of your personal history, all the colonoscopies you've gone through, all of the breast biopsies you've gone through, any cancer history that you have or any other medical things. It can include a targeted physical exam because some of these hereditary cancer syndromes have specific physical findings, skin changes, even head circumference is a common one. We want to know what the family history is, obviously, and we create pedigrees looking at least 3 generations of the family to track and identify different syndromes or genes that we might be worried about. We want to know if anybody's been tested in the family, what the background is, ethnic background, because we know in some populations, Ashkenazi Jewish, some Finnish and Norwegian populations, they have higher rates of genetic mutations. And then based on those things, we kind of try to put together what is our assessment of risk. And that risk includes the likelihood that if we go through with testing, we find a mutation, but it also what we do is talk about what is your risk of cancer even if we have negative genetic testing results. And so this is a key thing that's missing in a lot of the direct-to-consumer genetic testing is that the understanding is even if you are negative and we don't identify a gene, you might actually still be at increased risk. And how high is that risk? And breast cancer is one of the biggest ones we spend time talking about because we know if we calculate an increased risk or a personal risk of breast cancer in that 20% or greater range, we're going to follow you more carefully even without a genetic reason or a genetic mutation that we find. Because your risk is so great, we want to identify those cancers early. Colon cancer is similar. You can have a significantly increased risk of colon cancer based on family history alone. And so we'd want to do more colonoscopies more frequently or even earlier based on that family history. So this is a key component of that genetic counseling visit that is not just about the genetics. It's really about what is your risk based on cancer, based on this kind of family history that we create. The other key thing that we'd go through is looking and considering the types of results that we might find if we go through this testing. So it's pretty simple if you get a positive or a negative, but there's also a gray zone. Nothing in this world is black and white, right? Every test we get, there's always room for error. And with genetics, because we're all so unique and our DNA is so unique, there are all of these small changes in the genes that are of uncertain significance. And so it's just helpful to know about that prior to going through testing, so you would kind of anticipate that that could happen, and that doesn't mean that small change essentially has been found. It's usually a very small change, and there's no proof that increases the risk for cancer, but also just hasn't been seen before to the extent that we have enough information to know for sure that it's benign or just a regular change either. So that uncertainty can be difficult for people, and it's really important to talk about it before you get those results, so you've kind of at least had time to process that might happen. And then the other important thing is, genetic testing is all the rage right now, but you might not think about what it means to get a result that might be positive or might be surprising to you. And this is true with hereditary cancer genetics, thinking about what is your goal for testing and what are you going to do with that information. I'm biased. I think knowledge is power. You have the mutation or you don't, you should probably know about it. But it's important to think about what the road might look down the road if we find something. And how do we help you manage that risk? And starting to think about that even before testing is really important because it's a pretty big psychological challenge and dilemma to understand that you might carry one of these mutations. And there's not really much you can do about it, but you do have to live with this risk for the rest of your life. So we do spend some time kind of thinking through that and just helping patients understand some of the dilemmas and decisions they may need to make based on positive results or even negative or uncertain results. As of yet, in most states, there's no protection against discrimination or deniability for disability and life insurance, so that also is something to consider. I have a lot of young patients that are interested in testing, and I just have them pause for a bit and make sure, they just need to know that and understand that some of the other risks that might be unintended. We were joking last night that there are unintended consequences even of the ancestry tests. So, it's just important to kind of understand what you might be getting. And a friend of mine we were at dinner last night, and she was saying they had bought their dad, the Ancestry.com, and everything had gone fine, but she had been talking to someone else, and they bought the Ancestry.com and realized that her family history through the ancestry tree was Italian, but her dad's actually German, or it was some totally different ethnicity, and so you can get these unintended consequences where you actually find that maybe your biologic parents might be different from your familial parents, and so there are unintended consequences with all of these tests that are out there. So just my job is to talk about what some of the roads look like for the cancer genetics, but just be cautious even with the direct-to-consumer testing. There might be some different things that pop up. Okay. Take a break. We're going to talk about genetics, just a little bit of dry kind of reminder. So what are we actually talking about? I talk a lot about genes. What does that mean? Well, time out. Remember back, we have chromosomes and DNA in every cell in our body. The chromosomes are kind of wrapped up, or the DNA is wrapped up around all these proteins and formed into chromosomes. We have 46 chromosomes, half from mom and half from dad. Most of these cancer genes are not on a sex chromosome, which means they are not sex related, that women and men can pass these on to their children. What is the purpose of DNA? So DNA is the instructions for every cell function in our body. We inherit the DNA, it's the same in every cell. DNA is the recipe. The RNA is kind of that, the chef, and the chef is going to be, making like a shorthand version for the sous chef, and that shorthand goes out into the cell, which is the RNA, and your cell makes a protein, and these proteins are actually what do the functions. So that DNA is really what we're looking at and what the genetic testing is evaluating. Most of cancer genes are found in most cancer genes are actually involved in DNA repair. So if you have a mutation or a breakdown in that system, your DNA just can't heal itself from the day-to-day damages that undergoes it. So you had a glass of wine for dinner, or you're out in the sunshine and you didn't put enough sunscreen on. You have, mechanisms to help heal your body. The cancer genes, the majority are in DNA repair, and so if those proteins can't do their job because they have, been mutated, that cell can gather more and more mutations and then develop into cancer. So that's really kind of how a lot of these cancer genes have been identified, is looking within these pathways involved in DNA repair. There's a lot of types of changes that can happen to your DNA. Some we really care about because they can cause big problems with protein, like deletions and duplications, even inversions where the chromosomes get, switched in half, or even translocations where some of the DNA from one chromosome is on another. And it's important to talk about this because we know this now, that some even BRCA mutations happen with rearrangements like these translocations. And back in the early 2000s, the BRCA testing wasn't looking for rearrangements. And now we recognize that this is a true thing. And we have testing that looks for all of these types of mutations. So that gets to kind of where the technology continues to grow, and we might even discover more mutations based on how the genes and DNA can change within themselves in cells. SNPs, I just want to take a break and talk a little bit about this. The big changes in DNA that actually lead to a broken protein that cause cancers are those big deletions, those really big changes and disruptions. Some can also be just one base pair. You remember the DNA kind of has like that code, a bunch of little letters in the ladder. You can have one just substituted, where you, instead of having like a C, you get a G, and the whole code gets broken. Most of the time, those small single nucleotide variations, that just one base pair exchange, isn't enough to really disrupt the protein. If you're reading a paragraph and the bottom, one of the words in a sentence gets deleted, you can still pretty much make sense of that paragraph or that sentence, which is kind of what a SNP is. Most of the ancestry and even some of the 23andMe genetics are all based on these SNPs, which is harder to prove actual risk based on because they're such small changes. That's just a background piece. So I was thinking about genetic testing and how much I feel like it's changed. So I went kind of and looked at a timeline. I have a couple of slides. This just shows that one of the very first genetic diseases that we discovered was sickle cell in 1949. The discovery of the double helix of DNA was 1953. So it hasn't even been 100 years yet since we discovered like the structure of DNA. We used to have PCR, let's see here. The development of a DNA sequencing technique was 1977. So our ability to actually look at DNA and sequence all those letters was 1977. Next generation sequencing, which really is what has led to this massive increase in our abilities to understand and evaluate DNA, wasn't until 2009. And then when we think about kind of cancer genetics, 1994 is when BRCA1 was first discovered. And BRCA1, when it was first discovered, actually was patented. Those mutations were patented, and so other labs couldn't perform the test. And so there was a big Supreme Court case in 2013 which ruled that genes and DNA cannot be patented. And after that, the options for genetic testing just significantly increased, which was great because we talk about access issues. You really want competition in this marketplace to actually help improve access for patients. The first kind of big hereditary cancer panel, 2012, with Ambry, is a common company. So that's only about, 9 years that company, or 7 years that company has been around. Pretty early. We're pretty early in this genetic testing world. Really the last 10 years since the advent of next generation sequencing have we really started to refine and understand DNA. So that's just some background about why things are changing so rapidly. Because the technology, 2009, really this next generation sequencing, has only been around for 10 years, and that's what's given us the ability to really better understand cancer genetics. Okay, we talked a little bit about options. So if you come see me or a genetic counselor, there's a clinical test that we can order as physicians that usually is a panel, and these panels are unique. They can be specific to breast or colon. My general philosophy is that family histories are kind of poor sometimes, so I like bigger panels, but not too big that you don't know what to do with the results. So it's kind of like Goldilocks. You want something right in the middle where you're not going to miss something, but not to the point where you have a result that you may not know exactly what to do with. So right now what we have as options, Invitae has a 47 or 83 gene. That's kind of their two standard panels. Myriad is now 35 genes. It's been 28 for about the past year, and then they added a bunch of genes. Ambry has a lot of different options between tests for 14 up to 67 genes. And then there's something called Color, which is a 30 gene panel. There also is direct-to-consumer testing. You could, right now from your cell phone, if you're bored, order a genetic test. You could go to either 23andMe, and I think it's $99, and you would get a test for 3 variants, or only 3 mutations that we understand are related to BRCA, or you could order color. So color is a test that I order in clinic that is very good, but their other philosophy is that they want to improve access. So you could right now go to colorwebsite.com and order a test for $250, and it would be for 30 genes, the exact same genes that I order if I choose that test in my clinic. The downsides, as I mentioned before, is there's not pre-test counseling, but there is post-test counseling if you're found to be a carrier. They will go through that with you and set you up with some referrals. When you see someone in the office, usually we bill insurance, and that gets covered to some extent. All of the direct-to-consumers you're paying out of pocket, but you're at least knowing what you're getting. I'm going to skip that. So this is the example of color, just because it was the easiest to fit on a slide, of all the different genes that we usually get in a panel. And so that we're looking broadly for the most common genes that are related to breast, ovary, uterine, colon, melanoma, pancreas, stomach, and prostate, which are all the most common cancers related to hereditary cancer syndrome. And why panel testing is so important, I'm going to get to in just a couple slides. The reason why we've kind of moved from 1 and 2 now to these big panels. So it's just important to know that direct-to-consumer testing is out there, but all the experts say proceed with caution. So either really understand what you're getting or understand what you're not getting in terms of access to counseling and such. So just go in eyes open. A couple things about the 23andMe. This was a hot topic, so I do want to just really talk about what you're getting. The 23andMe is a very limited analysis. We know that there are thousands of genes that are pathogenic in BRCA1 and BRCA2, thousands of mutations that actually increase the risk. If you decide to choose the 23andMe right now, you're only getting 3. Those 3 are the Ashkenazi Jewish founder mutations. If you are an Ashkenazi Jewish woman, that test is probably pretty accurate for you. If you are not, that test is not accurate for you at all, and it's not worth your money. I would highly recommend you save it and spend it for something else, either a genetic counseling visit if you're that concerned, or considering color where you're going to get that entire gene sequenced, not just looking at those 3 spots. Oops. This kind of just shows you in the red here, it's hard to see, but that is the percentage of mutations that the 23andMe is looking for compared to all the ones that it's not. The purple is what it's not looking for. The red is what it's looking for. So it's really good. It's a very accurate test for those 3 mutations, but you're really looking at one itty-bitty sliver piece of the pie. In addition, recent data, this is a genetic counselor that works with Ambry. The other thing that can happen with either Ancestry.com or 23andMe is you can ask for all your DNA sequencing information to be given to you, and you can upload that into a computer program. And they'll look at they will go in and look at your BRCA1 and look at your BRCA2, and they might tell you, this kind of second company, that they find a mutation. But proceed with caution, because the false positive rate's almost 40% with that analysis. Just means that test and how they do the next generation sequencing might not be vetted to the level that it needs to be to identify these gene mutations. So I ask you to proceed with caution if you go down the road of direct-to-consumer testing with a company that's not vetted or does not generally do a medical grade test. And a lot of patients come to me with pages of DNA that they've gotten from Ancestry or 23andMe and uploaded to, I can't remember what it's called, but another company that will analyze it. Up to 40%, it's incorrect. So it's either causing a lot of false anxiety or missing something. There's also false negatives here. So just more word for caution. And then again, I like a broken record. There's no pre-test counseling. There's no assurance that you can understand the negative implications of these testing. So the couple last point is that we're not very good at testing. I talked to you about the importance of it and who should be tested. Ovary cancer, since we had these tests, it's always been 100% of women with ovary cancer should undergo testing. This was a paper published in 2017 based on a large, United States SEER database. That the blue here is the people that actually underwent testing. Rate undergoing testing, 10% with people with ovarian cancer were actually undergoing testing. You don't even have to think about it. You don't have to think about age or family history. It's easy. So this is relatively new data. We're doing a poor job. Why is that? It's multifactorial. Access is key. Understanding who should be testing is key. We need to make this a little bit easier. The other problem we're having with genetic testing right now is that traditionally, we went through family history and used that. Breast cancer is the best example of that. We use that to determine who meets criteria and who does not. Recent studies, this was published in 2018 in JAMA, shows that in this group of people, they looked at, it was an insurance panel. They looked to see how many, I think it was actually a genetic testing company. They looked to see how many positive mutations that they had found. And they went back and said, okay, we had all these BRCA mutations, and let's look at to see if they met the guidelines based on the NCCN. Half of those patients did not meet guidelines. So if I would have seen them and gone through those NCCN guidelines, they might not have had all that, might not have exactly matched the guidelines, and we would have said, well, you don't meet the guidelines, your insurance company is not going to cover testing, so this is most likely not hereditary. But in up to 50% of cases, we're missing high-risk mutations like BRCA. So that's a problem. This is another paper saying the exact same thing, but this really looks at not just BRCA, but those other genes we talked about. So some of these other genes, they don't have as high of a cancer risk, so the family history isn't as strong. You're not seeing as many breast cancers. And again, in this paper, 50% of patients who had mutations did not meet criteria based on the NCCN. And this, again, was the 2017 criteria, which is, again, as I told you, different from now, but really missed half of people. Half of people who had mutations didn't meet criteria, and thankfully they still underwent testing. So I think what's going to be happening and what we're seeing in the world is that for breast cancer specifically, we now know we're missing a bunch of people, so we probably should liberalize the guidelines. The fact that we're missing people because family history is not perfect, and we're also missing people because some of these other mutations, if the risk of cancer is only 30%, you might just not see those cancers pop up in family history. And so they're never going to have that family history that makes you that worried, but we still know they're at higher risk. 30% is 3 times higher than the 12% that's in the general population, and we should be helping those women and personalizing their management strategy so that we can detect these cancers early, which is curative. So this year, January, February, the American Society for Breast Surgeons came out and said, we recommend all women with breast cancer undergo genetic testing. It says right here, genetic testing should be made available to all patients with a personal history of breast cancer. So that has not yet been adopted by NCCN or insurance companies. But I will tell you, when every patient I see, if they have a history of breast cancer, we know that even if insurance companies don't pay for it, we have access to testing through that company called Color, which is $250, and you can get a medical grade test even if you might not meet those criteria for the reasons I said before. Up to 50% of patients with a mutation don't meet those criteria. So we need to be doing a better job at getting people who meet criteria testing, and we also need to be doing a better job at just broadening who should get testing, because we know there's mutations out there that we're missing. And I applaud the American Society of Breast Surgeons for kind of really coming out there and just putting it like it is. Okay. One last side note, most of breast cancers are sporadic, so don't forget about doing all the healthy things that you can to decrease your risk. Unfortunately, the rates of breast cancer are actually going up, mostly in the white women, less than 50. It's going up 1.7% per year. So this is breast cancer data from SEER. White women less than the age of 50, this is the rate of rise. For Black women, it's been less than 50. This has actually been stable or going down most recently. And then white ages over 50, recently pretty stable, pretty flat. And then Black women above the age of 50 also significantly on a rise here. So unfortunately for all of these groups, it's going up about 0.3% per year. So that's not great statistics. And then half of these cancers are preventable. So because the majority are sporadic, there are things that we do in our day-to-day activity that increase our risk. So we should be maintaining our weight, we should be walking, avoiding alcohol, considering chemo prevention for some patients at increased risk. So even though I love talking about genetics, we shouldn't forget that the majority of breast cancers are actually sporadic or from exposures that we have in our own life. Okay, I think that's everything. And questions at the end, or? Okay, beautiful. Thank you.
I'm much shorter. Okay, hello. So I'm Jennifer Garreau. So I'm one of the surgeons here in Portland. I work at Legacy Good Samaritan Hospital. And I just wanted to start off by thanking everyone that's here today. Thank you for coming and participating in our conference and supporting Susan G. Komen, because obviously it's not only important for all of us to learn and have information, but to support Susan G. Komen in the mission, which is to not only help women that have breast cancer, but also to support research and funding and stuff. So maybe someday there won't be breast cancer. We don't even be talking about this, but that might not happen in our lifetime. Anyways, thank you for being here. So I'm going to follow up with what Dr. Westhoff was saying. So she talked all about genetic testing, whatnot. So I'm going to talk about what happens if you are found to have a genetic mutation. What then? And I'm going to specifically focus on in regards to like breast cancer, stuff like that. So for a lot of people, they might, they're told you have a genetic mutation, and for some people, this might be how they respond, panic and all that stuff. But I'm here to reassure you that it's going to be okay. So there are things that you can do if you are found to have a genetic mutation. So let's go over that. So also, as Dr. Westhoff already discussed, the vast majority of breast cancers are not related to inherited genetic mutation. So it is also important to remember that because the vast majority are not related to a genetic mutation, very important that all women starting at age 40 get annual mammograms, okay? Because we all are at risk. The two biggest risk factors for getting breast cancer are being a woman and getting older, and we can't change that. So just make sure you get your mammogram. And as Dr. Westhoff pointed out, only a very small proportion of breast cancers are actually due to an inherited genetic mutation. Now, the vast majority of those inherited genetic mutations are due to BRCA1 and 2, and so that's what I'm also going to focus on in terms of screening and surgery, stuff like that, are for individuals who have that specific mutation carrier, but I'll talk about some of the other ones also. She also pointed out, Larry just said that while the BRCA1 and 2 account for the vast majority of genetic mutations, look at all the other genetic mutations that we now know can contribute to breast cancer. So again, following what Dr. Westhoff was saying, it's important that if you have had genetic testing, you make sure you had extended panel testing. Also, I have no data for this, but I just want to give you my bias, because I can. I would be careful going to those consumer groups, like who knows what they're doing with your DNA, and they're not medically licensed professionals necessarily that are checking your genes. So if you are interested, I personally would recommend that you go to a genetic counselor or someone who's trained in that. That's my bias, sorry. Okay. So again, there's many different genetic mutations that can increase your risk for breast cancer, and not all of them necessarily mean that you absolutely have to have mastectomies, which means removing all the breast tissue. Sometimes you can just do increased screening. Some women opt for surgery, and we'll discuss surgical options. And then also, what about chemo prevention? That's taking a pill that can lower your risk of breast cancer. Is that effective? Is that not? So again, as we discussed, the cancer risk in BRCA mutation carriers is significant. And that's why I'm spending most of my time talking about this, because patients that have either a BRCA1 or 2 mutation have a significantly elevated risk in their life for developing breast cancer. BRCA1 mutations can be, I would say that 72% I put on the slide is actually low. It's probably closer to like 80+% lifetime risk for developing breast cancer. And the BRCA2 mutation carriers, it's a little bit lower. It can be anywhere from like 40, 60%, but that's significant. The average risk woman has about a 12% lifetime risk for developing breast cancer. So this is very elevated, and they definitely should consider doing something, whether it be increased screening, chemo prevention, or surgery. Now, interestingly, men can get breast cancer too, even without a genetic mutation. So about 1% of all breast cancers are seen in men. And then specifically with BRCA mutation carriers, The BRCA2 mutation seems to confer a higher risk for breast cancer in men as compared to the BRCA1 mutation. And I put some numbers down here. The lifetime risk in men who are BRCA1 mutation carriers is about 1%. For men that have a BRCA2 gene mutation, it's about 7 to 8%, and the general population is only about 0.1%. So you can see that's significantly elevated. So they also should undergo screening. By the way, if it's a man that has a BRCA mutation carrier, they need to get breast cancer screening as well. Okay, so let's talk about some screening recommendations. So one of the first things and the easiest things I discuss with my patients is self-breast exam. We recommend that this starts at age 18, and it's mostly to facilitate awareness of changes in the breast. I'll be honest, there's actually no study that shows that self-breast exam leads to earlier diagnosis of breast cancer. However, I think it's very important for women to become familiar with their own breast tissue. I have a lot of women that they say they're nervous about doing self-breast exam, or it makes them anxious because they have so many lumps and bumps. But I remind them it's important to just become aware of that. Know what your lumps and bumps are so that if something new comes up, you're aware of it and you can discuss this with your doctor. So things that you might look for on self-breast exam are like an obvious lump or a mass. Maybe your nipple's getting pulled in and that's new. You can have dimpling of the skin, nipple discharge. Maybe you develop a new rash that doesn't go away. And then different types of skin changes. So it's important just to look and be aware of what your breasts look and feel like. We also recommend a clinical breast exam every 6 to 12 months. And this is a breast exam that is done by some physician. What I generally do for my patients is I kind of share the duty, if you will, with their gynecologist. And I say, you come see me once a year, you go see your gynecologist once a year, but you split it so every 6 months some physician is doing a breast exam. That's how I like to do it. Also, it's recommended, and remember, these are recommendations for BRCA mutation carriers, not for the general population. But we do recommend breast MRI starting annually at age 25. And then again, it can be earlier depending on what your family history is. For example, if you have a family member who is diagnosed very young, you might want to push that down. But in general, the recommendation is starting at age 25. MRIs definitely have been shown to increase breast cancer detection rates. It increases the number of patients diagnosed at an earlier stage of disease. And so for all of these reasons, screening breast MRI are cost effective and supported in multiple guidelines. Interestingly, though, it's not clear as to whether or not screening breast MRIs lowers breast cancer mortality. We don't know that right yet, but it definitely is a useful screening tool, and we still recommend that you get screening MRIs alternating with mammograms. So we recommend that women who have mutation carriers get mammograms starting at age 30. And I mean the one where you go into the breast center and your breast gets compressed, not these graham crackers with marshmallows. But anyways, again, so we recommend mammograms starting at age 30. This can change, again, depending on your family history. For example, if someone in your family was diagnosed very young, we might change that recommendation. And then again, I mentioned that we do recommend breast MRIs alternating with mammograms every 6 months for increased screening. One thing I will say, though, interestingly, there's no data that shows that staggering it like that leads to improved outcomes. You actually can combine both of them. Some of my patients like to do the mammogram and MRI at the same time every year. That's fine. Some of my patients prefer to split it up every 6 months so that they're having some sort of imaging every 6 months, and that's fine too. It's whatever works for the patient, but they should be getting both tests. The other thing I wanted to address is I have a lot of patients tell me, well, if MRIs are so much more sensitive than mammograms, do I have to get the mammogram? Yes, because MRIs and mammograms look at two different things. Breast MRIs tend to look at blood flow patterns in the breast tissue. It also can look for masses and different anatomic details like that. Mammograms specifically, they can detect something called calcifications, and those are generally only seen on a mammogram, and sometimes that's the first indication that there's some sort of cancer brewing or starting in your breast. Mammograms also look for something called architectural distortion. It just means the tissue looks funny, and that can only be seen on mammograms. So again, it's really important that both of these studies are obtained. One is not necessarily, does not replace the other, so you need to get both. Now what about ultrasound? Now, specific to mutation carriers, large studies have not shown any addition or any benefit to adding ultrasounds if you're already getting mammograms alternating with breast MRIs. So we don't routinely recommend that. Now, some of my patients, for whatever reason, don't want to get MRIs, and in that situation, I will add the screening ultrasounds. But I'll be honest, screening ultrasounds aren't really that great in terms of detecting breast cancer, so I really do recommend the mammograms alternating with the MRIs. Okay, and so let's talk about chemo prevention. So one thing you can do is something called endocrine therapy. I like to refer to this as anti-estrogen therapy. These are pills that essentially lower your estrogen level in two different ways. One is with something called tamoxifen, which that blocks the estrogen receptor, so that estrogen doesn't have an effect on the cells in your breast specifically. The other way that chemo prevention can be obtained is with something called an aromatase inhibitor. So an aromatase inhibitor, what that does is all us women, we all make the male hormones, the androgens, and those get converted into the female hormones, the estrogens, by an enzyme, and that enzyme is called aromatase. So an aromatase inhibitor, it blocks that enzyme, and then it prevents that conversion of the male hormones being made into the female hormones. And so then the estrogen levels kind of drop down to 0. And, I just realized I was supposed to change slides. Sorry. Okay, so specifically, endocrine therapy can be used mostly for BRCA2 mutation carriers. We know that BRCA2 mutation carriers have a higher incidence of hormone receptor positive breast cancers, whereas BRCA1 mutation carriers, they tend to have a higher incidence of something called a triple negative breast cancer. That's a more aggressive form of breast cancer, and what that means is that those breast cancer cells don't respond to hormones, so giving a pill that lowers your hormone level is not going to make a difference. But for female BRCA2 mutation carriers who opt to not get risk-reducing mastectomies, you can offer either tamoxifen or an aromatase inhibitor. However, in these patients, if these patients initially say that they don't want surgery for prophylaxis, you really should bring it up every once in a while and make sure that it's rediscussed, that they either do or do not want surgery, because while chemo prevention can lower your risk of breast cancer, it doesn't eliminate it. And remember the numbers we showed you, the risk is high in these patients. So even lowering it, it's still higher than what the average risk population is. So you really need to keep readdressing, like, are you sure you don't want surgery? Is this an okay way for you to proceed? Yeah, chemo prevention is definitely less effective than surgery, but certainly something that can be done. Okay. So going along endocrine therapy, I kind of discussed some of this. There was a big trial that looked at women that had breast cancer and then had genetic mutations, and they found that in BRCA2 mutation carriers, tamoxifen lowered the risk of breast cancer by about 62%. Now that sounds really significant, but you have to remember that this specific trial was limited by the small numbers of women that had mutations. So you can see in this, only 8 of 288 women in this study that had breast cancer had a BRCA1 mutation, and 11 out of 288 patients that had breast cancer were BRCA2 mutation carriers. So again, that's a really small group of women, so I would argue it's hard to make very sweeping declarations that, yeah, you can have this significant risk reduction in such a small group. And again, as I mentioned, endocrine therapy is only effective against hormone receptor positive tumors. It will not lower your risk for developing a hormone receptor negative breast cancer. And what about birth control pills? Are those safe? So there are studies that show that birth control pills do reduce the risk of ovarian cancer in BRCA mutation carriers. There is a theoretic risk of increased breast cancer risk, but I will be honest, it's not clearly supported in the literature, and there's no good data suggesting that. So I actually tell my patients it's okay to take birth control pills. And then specifically just for the average population, birth control pills are definitely safe. So there's no harm in taking those. Okay. So this is really what I was here to talk to you guys about, is risk-reducing surgery if you have a genetic mutation. So when I say risk-reducing surgery, what I'm referring to is bilateral prophylactic mastectomies. And what that means is removing all the breast tissue on both sides to prevent someone from developing breast cancer. The NCCN guidelines, which NCCN stands for the National Comprehensive Cancer Network. It's kind of a governing body that sets out guidelines to help us determine or give the best care for all our cancer patients. The NCCN guidelines do recommend that all BRCA mutation carriers be offered risk-reducing mastectomies. And the reason is because, remember, that risk is so high for them developing breast cancer. I actually tell my patients that it's not so much if you're going to get breast cancer, it's when. And that might be a little bit dramatic, but I mean, it's very high risk. Risk-reducing mastectomies, it decreases the risk of breast cancer by greater than 90%. Why is it not 100%? Well, even in the best of hands, there probably is some breast tissue left behind after a mastectomy, and so that's why it's not 100%. However, most studies have shown that women with BRCA mutations who undergo prophylactic surgery, they don't develop breast cancer afterwards. And I put some data here from a very large study, and it showed that of 247 patients that underwent prophylactic surgery, none of them developed breast cancer, versus over 1,300 patients who were genetic mutation carriers, did not have prophylactic mastectomies. 98 of those women went on to develop breast cancer. So it significantly reduces your risk of developing breast cancer. Now, what kind of mastectomy can you get? Some of you might be aware of this, some might not, but there's actually different types of mastectomies that we can do. So one is something called the traditional or skin-sparing mastectomy. What that means is you remove all the breast tissue along with the nipple areolar complex. That's a standard or traditional mastectomy. Some people call it a skin-sparing because you try to save as much skin as possible. Now, the other way we can do it is with something called a nipple-sparing mastectomy. And that is what it sounds like. You save the nipple areolar complex. Oh, I'm being told I have 5 minutes. Okay, I'm going to hurry up. Anyways, but nipple-sparing mastectomies, they look better because you save the entire skin envelope, nipple areolar region, but not everybody is a nipple-sparing mastectomy candidate. So this mostly is dependent on the size of your breast and the position of your nipple. If your breast is too large, then the risk of something called nipple necrosis or ischemia is much higher. Also, if the position of the nipples is kind of low or hanging, if you save that, the cosmetic outcome is not going to look that good. What about checking the lymph nodes in prophylactic surgery? So I do recommend that specifically for my BRCA mutation carriers because there is a risk of something called occult malignancy that can be as high as 11% in mutation carriers. And what that means is that even if you've had a mammogram, an MRI, like full imaging workup that shows nothing, at the time of surgery, it is possible that on the final pathology, they might see a cancer. And so in that situation, you want to make sure that you check the lymph nodes. So I routinely recommend that. Okay, so let's look at some pictures. What does this all look like? So this particular patient had a skin-sparing or traditional mastectomy. Hold on, I gotta get the pointer. These pictures here, that's what she looked like before surgery. Those are her native breasts. These pictures over here are what she looked like after all her reconstruction was said and done. And she had her nipples tattooed here and here. You don't have to get nipple tattooing. Some women like to get it. Some of my patients are just done. By the time they're all said and done with everything, they're like, that's the last thing I want to do is get a nipple tattooed. But this is just an example of a patient who did have the nipples tattooed afterwards. So that's one example. Oops, oh, that was the pointer. Oh, okay, sorry, it's hard for me to see over here. Okay, so this is a lady, did not have a genetic mutation, but she had a left breast DCIS. You can see her lumpectomy scar right there. And then she developed a right-sided breast cancer. She was not a genetic mutation carrier, and she opted to keep her left breast, and she only wanted to have a mastectomy on the right. I can't remember why, but that's just what she decided, and that was fine. So this is what she looked like beforehand. And you can see the front view on my left, I guess screen right, and this is the side view. And the right breast is the one that she had the mastectomy, okay? I want you to remember that. So this is what she looked like afterwards. Now this is the breast that was reconstructed, and you can see the incision here on the side. We did a nipple-sparing mastectomy, which again, you save the entire skin envelope, nipple areolar complex. And she had something called a deep flap reconstruction. What that is it's when you use your tummy tissue to make a breast. That's why she has this incision down here along her tummy, because that's where the tissue was harvested to make the breast. That's a very big surgery, both in terms of time in the operating room and recovery. Not everyone is a candidate for it. You have to have, again, like the Goldilocks thing, you have to have just the right amount of tummy fat. If you don't have enough, you can't do it. And interestingly, if you have too much, you can't do it either. So I know that seems weird, but it's true. Anyways, so she had an excellent cosmetic outcome, and that's what that looked like. So let's continue. This is a patient of mine who she did not have a genetic mutation, but a very strong family history of cancer. And so she opted to undergo prophylactic mastectomies because she was really worried about developing breast cancer in the future. So this is what she looked like beforehand, and we performed a nipple-sparing mastectomy with implant reconstruction. So different than that last one, which was using your own tummy tissue. And this is what she looked like afterwards. So she had a really good outcome. In her situation, we put the incision here. I don't know if you can see it at the inframammary crease, it's a little bit, but we kind of hide it. We used to do something called a radial incision, which is when you put it out laterally going from the nipple, but now we tend to just try to hide it in that inframammary crease. Yeah, I'm almost done, thank you. But we try to hide the incision in that inframammary crease because then there's no scar on any of the overlying breast tissue, so it looks really nice. And then I think this was my last picture. This is a patient, no genetic mutation, but young and diagnosed with breast cancer. And this is her pre-surgical pictures, pre-surgical pictures on the left, screen left. And this is what she looked like afterwards. And again, you can't really see her incisions because they're hidden here in the inframammary crease. So she had a great cosmetic outcome also. And this was implant-based reconstruction. She definitely didn't have enough tummy tissue to make a breast. And then, this wasn't my patient, but she also had nipple-sparing mastectomies. You can tell because I can see the scar hidden down here. So she had a really good outcome too. So, as I mentioned, there's a bunch of other genetic mutations that can increase your risk for breast cancer. Interestingly, the BRCA1 and 2 mutations are the only ones that currently the NCCN guidelines recommend, strongly recommend risk-reducing mastectomy. These other mutations that can be associated with breast cancer, they mostly say you need to have increased screening. Risk-reducing mastectomy is recommended in some of these patients based on family history because, again, the penetrance or the impact of each genetic mutation can be different based on your family history. But mostly for these other ones, it's increased screening with risk-reducing mastectomy as an option if you have a really strong family history. And then I'm not going to talk about that. Last thing, if you do have a genetic mutation, specifically with BRCA2, it's not just about breast and ovarian cancer. You are actually at higher risk for some other cancers, specifically like melanoma, pancreas, maybe colorectal cancer. And so you need to discuss that either with your genetic counselor or your provider to figure out if you should have increased screening for those cancers. And that's it. And thank you so much for your attention. I really appreciate it.
Thank you so much. Okay, so we have about 10 minutes for questions. On your tables, you'll see cards like this. So go ahead and put some questions down and hold them up. And we have Jeannie right there who will pick them up and bring them forward. Would you both like to come back up? And we had one question from the simulcast group. It won't take long.
Oh.
I don't think so. So someone asked from the simulcast, said, I had a stainless steel plate put in my arm. Can I still get an MRI? And I'm pretty sure the answer is no. If you have any metal in your body, you can't get an MRI. That's actually one of the questions they ask before you get any MRI. Do you have a comment on that? Oh, okay, sorry. So, no. Any other questions? Yeah. Oh, sorry, I'm going to ask that for you. That was mine.
I didn't have one for you. I didn't know. I didn't know you were going to come at me like that. Question, if you do have mutations like BRCA, will insurance cover the preventative surgery? In most cases, the answer to that question is yes, in my experience.
Yeah, sorry, I just want to say also that in Oregon, in the state of Oregon, reconstruction, it's mandated that reconstruction is covered by your insurance. Now, granted, that's only in the state of Oregon that I am aware of, because that's where I work. It might be true in other states, but the reconstructive portion of the surgery has to be covered by your insurance.
The caveat to this surgery is, if in my world, for removing of ovaries, there are it can be difficult for some state insurances to actually have that part of the risk reduction covered. So sometimes we have to fight and argue and have a workaround. But the majority of cases were successful. Is it okay to test for just one mutation when it is known that a parent has that mutation and no other known family history of different cancers? That's a great question, and I generally talk about that. In most cases, we actually do recommend still doing panel testing. That is my bias, even with a very strong family history that is negative. Because there are these mutations that might not have as strong of a risk, you may just not see it in that family tree. Or in mutations that are specific for breast cancer, if there's a lot of men on that side, you also may not see it. And in general, I have a personal discussion. In most cases, I do recommend panel testing, just because we do know we pick up mutations a lot in a significant number of people when we do full panel testing, even if there's just one. I mean, I had a patient come in yesterday, and thankfully she had a family history of a mutation, but cancers on both sides of the family, so it wasn't quite clear where this was coming from, so we did kind of the full panel for her. My bias is yes. Some people would tell you no. My bias is yes, because we do miss things even in patients with no family history. Okay. Do you want to read that one?
So this question says, I'm 73, have no kids, and I'm a breast cancer survivor. Should I get tested in hopes this would benefit my nieces, nephews, and future children?
Yeah. I would say my bias is that yes. I think that even though I think the access to genetic testing is such that for the main downsides of testing, in my opinion, for patients with cancer is cost. Because if you already have a cancer diagnosis, that we really are not as worried about some of these insurance issues, because you have this pre-existing condition that's going to take you out of that market. At age 73 in general, you're not looking at life and disability insurance in most cases at that time anyways, and it does help inform your family history. Because if I see a patient and it's your niece, and she knows about your breast cancer and maybe there's one other family member, she meets criteria, but it's not as useful to test people without cancer. You really want to get the people with cancer tested, and yes, I would recommend you have genetic testing. This is probably a good one for you.
Oh, yeah. What about cumulative gadolinium with MRIs? So there is some recent data showing that the dye used, with the dye used for MRIs, that it seems to, some of it accumulates in the brain. Now, they also say that that doesn't cause any problems, but I mean, I don't know. Dye in the brain just doesn't sound good. But the studies so far have not shown that that seems to be a problem. Now, the other thing is not all dyes are created equally. Some of the gadolinium dyes used for breast MRIs have greater penetrance into the blood-brain barrier and then therefore into the brain. I can't speak for other health systems because I don't work there, but specifically at Legacy, the gadolinium dye used for the breast MRIs actually has very low penetrance into the brain, and so it's safe. However, that is an excellent question and something to be aware of, and you really need to ask your facility what kind of dye they're using and is it associated with increased accumulation in the brain. Like I said, at Legacy, the dye they use is pretty safe, actually, but something that you should ask your imaging facility.
Question here is, can you go back to a genetic counselor after already doing testing and knowing you have a mutation? The answer is yes. And, the genetic counselors are such a great resource. I have some subspecialty training in genetics and genetic counseling in particular, but there are even patients of mine that we partner so much with our genetic counselors because of their unique knowledge. And even if you didn't have a mutation, you can go back and see your genetic counselor to ask for an update. You can bring your test result 1 or 2 years later and say, is there anything new for me, anything else I should be considering? Either based on changes in family history or just wanting to know what's new and different in the recommendation world. Also, women with variants of unknown significance, we do recommend that they go back and have a conversation. Has that variant, do we have more knowledge? Has it been reclassified? Do we have more information now about what to do with that? So yes is the answer, and I encourage it for lots of reasons, those I discussed.
We're going to try, there's 3
Yeah.
more questions, and I think do we have to wrap it up? Who's in charge of time? We have 3 minutes. Okay, so I think we can get through these 3 questions. And then we'll be around a little bit to answer questions.
If you get testing and have the BRCA gene, will insurance cover should you develop breast cancer? The answer is yes. They will cover the screening tests that you are recommended to have, and then if you are diagnosed, also should cover care for that as well.
So another question I got was, is there any change in lifetime risk with nipple-sparing mastectomies? Which is an excellent question. And I had a slide on that, and I think I just blew through it. I apologize. But the answer is this has been studied pretty extensively, and there's no increased lifetime risk for developing breast cancer later if you have a nipple-sparing versus a standard or non-nipple-sparing mastectomy. Nipple-sparing mastectomies initially actually were developed for women getting prophylaxis who had BRCA mutations, and then we translated that into women who have breast cancer, and we know it is safe from an oncologic standpoint, both if you have cancer and or if you have a genetic mutation. So the question is if you actually are a nipple-sparing mastectomy candidate, but that's safe. And then this next question is, what are the chances that cancers develop on the chest wall behind the implant? Are there screenings with bilateral mastectomies? So generally the way implant reconstruction is performed is the implant's actually placed behind the chest wall muscle. So even if you were to develop some sort of chest wall recurrence, you actually can feel it still on physical exam. So generally you don't necessarily need any additional imaging other than physical exam.
Couple questions. When do mutations happen? That's a great question. So these mutations, as we're talking about them right now, you inherit those from your parents. So you are just born with that mutation. I kind of did gloss over. You have 2 copies of every gene in your body, and so that one healthy copy really does take over and provides the function that gene should be doing. And cancers develop when you get a second hit to that gene through, an exposure or just age or time. And so you are just at slightly increased risk for cancer given that one mutations already knocked out that half of the gene that you have. So the mutations, standardly, these are inherited. There are very rare chances of having what's called a sporadic mutation. Some of the mutations we haven't talked about, that's more likely to occur, something called P53, where you can develop a mutation in your ovaries even, and then pass it on to your children. You're the very first person to have that mutation. That is extremely rare. Most of it is inherited. If I'm 0.3% Ashkenazi Jew, do I need testing? I would say, based on that fact alone, maybe not. I think looking at other family history and just interest, there are some new studies looking at should everyone have genetic testing at a certain age, namely the age I've seen most commonly is 40. And should we just test everyone for BRCA 1 and 2 at age 40? Is that cost effective, given that the cost of testing has dropped so dramatically? So that's kind of another interesting thought question for medical society is, given that testing is so easy, should we not just be looking for these very high-risk mutations that we want to do something about? And then there's a little family history question about a patient with a brother-in-law with pancreatic cancer. The truth of it is pancreatic cancer now is a testable indication. And so if a person has pancreatic cancer and is now deceased, the next person closest to them, siblings or parents, should undergo testing.
I just want to end it by asking I have a question for you, if that's okay. So if you get genetic testing, not with a counselor, you go, do your random online test, are those results reportable to either your insurance? Can you hide it from disability or life insurance? I mean, I don't know, right?
I think if they don't ask you, you can, right? I mean, you are, I think, as far as I know, and I'm not a lawyer, so, but, I just went through my own life insurance thing, and they actually didn't even ask me about genetic testing, which was interesting. Yeah, have you ever had genetic testing? They ask a lot about family history of cancer. So I think I think legally, if you are not withholding information if you are not asked.
Okay, that was my question. Thank you.
But I'm not a lawyer, so I can't testify for you.
Okay.
Okay. All right, thank you, everybody.
Oh, please join me in giving them a big round of applause. Thank you so much for spending part of your Saturday with us.